Alright class, today we're going to talk about breast cancer. It is the second most common malignancy in American women and the second leading cause of cancer death in American women following lung cancer. The American Cancer Society has published statistics for women with breast cancer. I think one of the big ones I see is about almost 40,000 women die each year from breast cancer, which is a staggering amount. There are many types of breast masses. There's benign breast lumps and there's malignant breast cancer. Some of the benign things that women feel or sometimes have to get followed up on are fibrotic changes. This is like scar tissue. Other things are cysts, which are fluid-filled, and there's fibroadenomas, endoductal papillomas. These are all non-malignant masses. And then there's malignant breast cancer. The different kinds are non-invasive. The non-invasive one that you hear of the most is ductal carcinoma in situ. Like it says up there, 22% of malignant breast cancers are non-invasive. Ductal carcinoma in situ is means that the cancer cells are only within the ducts, but have not spread into the walls of the ducts of the surrounding breast tissue. About 1 in 5 cases of people with breast cancer have this. It's very curable. 63 to 68% of women have infiltrating ductal carcinoma. The main ones I have listed there are invasive ductal carcinoma, inflammatory breast cancer, and Paget's disease. Basically, the cancer cells start in the milk duct of the breast, and then they break through the wall of the duct and grow into the fatty tissue. Next is invasive lobular carcinoma. This is whenever the breast cancer starts in the lobes of the breast, and I've got a picture here that it kind of explains. You've got the ducts right here that connect the lobes to the nipple. Now, inflammatory breast cancer, I want to spend a little bit of time on. It's one of the infiltrating ductal carcinomas because it's a bit different than regular breast cancers. There's generally not a lump that's felt, but women actually get this redness and hardness on their breast. They get this skin that's called peau d'orange. I actually brought a little grapefruit here to show you. Basically, their skin looks just like this. It's red, it's hot, it's inflamed. I've seen women, whenever I was working in a clinic in Laredo, that had inflammatory breast cancer, and she just kept refusing, denying that anything was wrong. It's a very aggressive form of breast cancer, and it got to the point her whole breast was becoming necrotic, just eaten away with cancer. And every time we treated her, everyone cleared the room except one person because it smelled so bad. It was really sad. She was just in denial for a really long time. Breast cancer in men, I do want to mention because a lot of men think that they can't get breast cancer, but it actually counts for 1% of all breast cancer cases. The average age is 60. Some of those signs and symptoms, they might have nodules that they feel, and gynecomastia, and also a nipple discharge. Most men, don't think that they're going to develop breast cancer, so it's usually found at a more advanced stage, and they have a poor prognosis. Some key terms that I just want to cover before we get too far into this starts with carcinoma. Now, carcinoma is a cancer that begins in the epithelial cells of the breast. So either in the ducts or in the lobes. So ductal carcinomas or lobular carcinomas. This is the most common. Then you have adenocarcinomas. It's a type of carcinoma that starts in the glandular tissue, and glandular tissue is tissue that secretes secrete substances. The like breast milk, and these are called adenocarcinomas. Carcinoma in situ, we talked about, it's an early stage of cancer, and the cancer cells are confined just to the walls of the duct or the lobes. And then you've got invasive or infiltrating carcinoma, which is what we've been talking about a little bit, and that's whenever the cancer is already gone beyond the layer of cells where it started, so it's no longer carcinoma in situ. Last is sarcomas. Now, sarcomas are cancers that start in the connective tissue, such as muscle tissue, fat tissue, or blood vessels, and these are rare with breast cancer. Okay, wanted to talk about some risk factors here. Gender is obviously a risk factor. If you're a female, you can't change that, but you have 100 times more risk than having breast cancer than men. Age, about 1 in 8 people with breast cancer are under 45, but most breast cancers are found in women over 55. Those that are younger that develop breast cancer tend to have more aggressive forms of cancer. Genetics. They're saying now, there's a lot of research out there now talking about the genetics and how it plays a role in breast cancer, and about 5 to 10% of people with breast cancer, they think, have it because of a genetic factor. The biggest factor they are looking towards and studying is the BRCA gene. So there's BRCA1 and BRCA2. And essentially these are genes that cause breast cancer. And we'll talk a little bit about it in a little throughout the presentation. Family history of breast cancer. So basically, if you have one first-degree relative, so a mother or sister that has cancer, that has breast cancer, then you have double risk of developing breast cancer. If you have 2 first-degree relatives, then you have 3 to 4 times risk of developing breast cancer. Those women that have dense breast tissues, so they've got more glandular tissue essentially and less fatty tissue, they're at more risk of developing breast cancer, and it's harder to detect because of the glandular, because of the the dense tissue. Now, menstrual periods, this is kind of interesting because a lot of breast cancers they grow because of estrogen. So those women who started menstruation early, before 12, or they had delayed menopause after 55, they have been exposed to estrogen for longer periods of time, and therefore, if they are higher risk of developing breast cancer, especially that breast cancer that grows due to estrogen. And women who've had previous chest radiation, so if they've had other types of cancer and they've had had radiation to their chest, they're at higher risk. There's a table in your book on page 311 that you can refer back to some of these. Okay, having children, it's proven that if you've had children before you're 30, that actually is kind of protective for you to have for not having breast cancer. So if you've had children after 30 or you've never had any children, then you're more risk. Also, those women that are on birth control or have taken birth control, they're at higher risk. But they say after about 10 years of being off the birth control, that risk diminishes. You probably have all heard about hormone therapy and how women who are postmenopausal get hormone therapy to help with the side effects of menopause. They're at risk. But the research now shows that there's no risk with just estrogen therapy alone. Now they have risk for other things when they're taking that. But breast cancer risks don't go up with only estrogen therapy alone. But if it's a combined estrogen-progesterone therapy, those women are more at risk. People who've never breastfed before are more at risk. They show that if you breastfeed for even a couple of months, that is protective and will prevent, to a certain extent, breast cancer. Also, it's proven that alcohol intake can cause can be a risk factor for breast cancer. Now, weight gain in adulthood, your fat cells actually secrete a small amount of estrogen, and so if you are obese or if you're gaining weight, it can actually cause more estrogen to be produced in your body and therefore feed any breast cancer that you have. So it can cause breast cancer. Sedentary lifestyle, high dietary fat intake, and that's mostly because it will cause weight gain, and previous exposure to radiation. Because radiation changes the structure of DNA, which can then cause cancer. Some myths that we need to address about what can cause breast cancer. There's, every couple years there's new studies out about what does and doesn't cause cancer. And you should eat eggs, you shouldn't eat eggs, you should eat fruit, you shouldn't eat fruit. Basically, the current research is stating that they haven't come up with anything in particular from diet or vitamins that causes cancer. It's more just if you have a poor diet that causes you to be obese, then you're more at risk. There's also been some internet rumors about antiperspirants causing breast cancer because of the chemicals and the proximity to the chemicals in antiperspirants and the proximity to your breast, but there's little evidence to support that. Also, there was more rumors about wearing bras causing breast cancer. The theory behind this was that it was obstructing lymph flow, but there's no scientific evidence that this does cause breast cancer at all. Essentially, what they've determined is that women who don't wear bras regularly tend to be thinner and have less dense tissue, which makes sense. Induced abortions, there's no evidence that shows induced abortions or spontaneous abortions, miscarriages causes breast cancer. And neither for breast implants. Breast implants don't increase the risk of breast cancer, but they can cause fibrotic changes that make it harder to detect. Also, night work, for those of y'all who plan on working at night, they specifically study nurses who work at the night shift to determine if that caused breast cancer, and they are still looking into that, but everything is leaning towards the hormone melatonin that fluctuates with those people who work night shifts, and so there's still research going into that, but there's no hard evidence that working at night causes breast cancer. So how do we prevent it? Obviously, we have those modifiable risk factors to decrease our body weight, which include changing our physical activity and diet. Also, we can encourage people to breastfeed, not to take the combined hormone therapy. There's also medications out there that are called chemopreventative medications. Specifically, tamoxifen and raloxifene have had a lot of research done lately. Whenever I first started working in oncology, I was working with a trial to determine if tamoxifen or raloxifene, which one worked better. It was called the STAR trial, and basically they determined that both of them have equal effects, and so you'll see some women on tamoxifen and some on raloxifene. But both of these drugs work similarly, and they block the effect of estrogen on breast tissue. Now, the aromatase inhibitors, like Femara is an example, this actually blocks the production of estrogen, and that will help prevent some breast cancers. But considering all these chemopreventative agents are dealing with estrogen, this only helps prevent breast cancers that are sensitive to estrogen, and we're going to kind of talk about that later. Now, there are some women who are at very high risk of breast cancer, those that have genetic predisposition, and there's ways that we determine what risk patients are at, and they can have preventative surgery like mastectomies and oophorectomies and remove their ovaries, which will help decrease their estrogen level. The preventative mastectomies, which is like a bilateral preventative mastectomy, will help decrease the risk of breast cancer in someone's life by 98%, and the oophorectomies by 50%. There's also been some research out there about the use of NSAIDs and bisphosphonates to prevent cancer, and that's just kind of new research that's out. So let's talk about screening. We mentioned earlier about the BRCA1 and BRCA2 genes. A lot of women choose to get genetic tested because they've had a first-degree relative, a mom or a sister, or a mom and a sister, have a history of breast or ovarian cancer. These genes actually are tumor suppressor genes, and so if without those, the cancers kind of grow out of control, and the cells grow out of control. So if you have mutated genes, if you've inherited the mutated genes, and you have cells that grow out of control, you're at more risk of developing cancer, and these people are at really high risk. Before any genetic testing, you're going to want to talk with probably a genetic counselor, because there's a lot of decisions involved with doing genetic testing. If you do find out that you have an abnormal BRCA1 or BRCA2 gene, a lot of women want to make decisions about doing some of the preventative surgery, like a bilateral mastectomy and possibly hysterectomy with oophorectomy, to decrease their risk. So you really want to counsel your patients before they do genetic testing. There's also mammograms, and that is an x-ray of the breast that help determine if there's any changes to the breast. There's clinical breast exams that are done in your physician's office, usually at a woman's yearly exam. And there are self-breast exams. And we're going to talk about how frequently these need to be done in just a little bit. So one of the things I did want to mention was about self-breast exams. These are kind of the instructions given by the American Cancer Society on how to perform a self-breast exam. And this is kind of new research out there, because used to, when we were taught to do self-breast exams, standing up in the shower, but now they recommend that you lie down and place your arm behind your head, because this will actually spread the breast tissue more evenly over the chest wall and make it as thin as possible, so you can feel for changes easier. So you should lie down and place your arm above your head. Use the finger pads of your 3 middle fingers on your left hand. There's a picture right there of your fingers that you should be using. You want to use an overlapping dime-sized circular motion to feel your breast tissue, and use 3 different levels of pressure. So just slight pressure, medium pressure, and deep pressure. You want to move around the breast in an up and down pattern, and I've got a picture here of which pattern you should follow. And then once you've done both sides, you're going to stand in front of a mirror with your hands on your hips and look at your breast for any changes of size, shape, contour, dimpling, redness, scaliness. You also want to make sure that you look under your arm while standing and feel that area, because I've got a picture here, not that one, sorry, here, that describes about where most breast cancers occur, which is in the upper outer part of the breast. That's where 50% of breast cancers occur, so you really want to feel and see if there's any nodules right there under your arm and in the upper part of your breast. These are things you're looking for, is just a lump or any skin dimpling, the changes in skin color or texture, changes in how your nipple looks, or if it's retracted in or pulling out, and if you have any leaking from your nipple. Okay, so the current recommendations for screenings are that women 40 and over should have mammograms every year. Women in their 20s and 30s should have a clinical breast exam every 3 years, and this has actually changed from previous recommendations where they had clinical breast exams yearly. Now, your gynecologist will probably still check you yearly because you're going in for your pap smear and lab work yearly. Even pap smear recommendations have loosened up since I've started nursing. They do pap smears every year and clinical breast exams every year, and now they do base it upon risk, but they still want you to come in every year. After 40, they recommend that the clinical breast exams do increase to every year. They want to tell women starting in their 20s that it's important to do breast self-exams. However, we do need to let women know that this isn't a replacement for getting their mammograms and clinical breast exams. Not all breast cancer can be detected by self-breast exams, so we need to just explain that to them. Women that are at high risk, greater than 20% lifetime risk, should get an MRI with their mammogram every year. And those people that are high risk have a known BRCA1 or BRCA2 gene mutation. They have a first-degree relative with the gene mutation. And they maybe not have gotten the genetic testing themselves, but that still puts them at high risk. There's different models that they can, kind of like almost like questionnaires that they can fill out and determine what their risk is. If they've had radiation therapy to their chest for any other reason, they're generally at high risk. So women just kind of need to know what their risk of having breast cancer is and get their proper screenings. Some signs and symptoms of breast cancer. The most common that people think of is the new lump or mass in their breast. But like with inflammatory breast cancer, you can have swelling or skin irritation. Sometimes you'll have dimpling or breast pain. Sometimes you don't have pain, sometimes you do. With a lot of cancers, we think of painless mass as a common symptom, but sometimes breast cancer can have a painful mass. Nipple retraction, redness, scaliness, or thickening of the nipple or breast skin, and also nipple discharge. So diagnostically, we do the mammograms, which are the breast x-rays. They'll do MRIs to get a better picture of the breasts. Usually they'll do MRIs and ultrasound following a suspicious mammogram. There's tests out there called ductograms, where they actually put a tube down one of the ducts, inject some dye, and then take some pictures and see if there's a mass that's blocking a duct. Sounds kind of painful. Then once they do these tests and they're really suspicious that it might be breast cancer, they'll probably do a biopsy to confirm. They can do different kinds of biopsies. A fine needle aspiration is whenever they just use a small needle hooked up to a syringe and they aspirate out some of what's inside a mass and look at it under a microscope to determine if it's cancer. They can also do core needle aspirations, where they use a bigger needle and kind of core out a sample. They can use vacuum-assisted biopsies, where they, it's kind of just like it says, they can use a little vacuum to suck out some of the cells. And if they need to, they'll do a surgical or an open biopsy. They'll sometimes call it an incisional biopsy, and this is where they can remove the entire lump. Whenever they do this, sometimes they need to use wire localization, which is essentially they use an ultrasound or an MRI to guide them to place a wire in the center of the mass, and it will help guide the surgeons whenever they're removing out the cancer, in hopes of having clear margins. Now, clear margins means that the pathologists look at, under a microscope, look at the lump that was removed, and they see if there is a transition from cancer cells to normal cells, and then they know if they have clear margins. I did a lot of my master's research in this area with one of the doctors that I worked with. Wanted to see if his technique of putting stereotactic wire was more effective and prevented women from having to go back and get further procedures done. And it actually showed he was doing a pretty good job. After they determine they have cancer, or sometimes after the biopsy, or sometimes they'll do it with the biopsy since the patient's already asleep, they can do lymph node dissections or sentinel lymph node biopsies. We'll talk about those a bit later. Once we've determined that the patient that the patient has breast cancer, a lot of times they'll do further radiology scans to check for distant metastasis. So they'll do chest X-rays to look at the lungs. They'll do bone scans. They'll do CT scans, usually all around the body, head, chest, abdomen. They'll do MRIs. They'll do ultrasounds, and they'll do PET scans. Just back to this real quick. PET scans, whenever you see the results, it just looks like an outline of a person, and you'll have areas that are lit up, and they're lit up because they'll show where there's rapid cell division and rapid cell growth, which generally correlates with cancer because it grows more rapidly than the rest of the body. Okay, labs that they do, obviously the pathologist is going to look at the cancer cells under the microscope to determine what kind of cancer it is. There's also MammaPrint and Oncotype DX, which is a genetic test that they can run on them. There's tumor markers, CA12-3 and CA27-29. A lot of times doctors will run these and use this as a kind of a baseline to see if the numbers decrease as they continue their patient on treatment. Also, if there's like metastasis, they'll probably want to look at liver function tests, CBC, calcium and phosphorus levels. The liver function test, obviously, if there's metastasis to the liver, they'll usually see a change. CBC and calcium phosphorus levels, if there's any metastasis to the bones, they can see changes. Okay, so the types of breast cancer. Basically, you can have non-invasive or invasive. We talked about DIC being a form of non-invasive. There's also ductal or lobular carcinoma in situ, which is LCIS. Most doctors don't even consider that a form of breast cancer. So that one, but it is a form of non-invasive. And then there's invasive cancer, which is the majority of our cancers. Our cancers can be ductal or lobular, because those are the two main structures in the breast. So then after we've decided that they're non-invasive ductal carcinoma or non-invasive lobular or invasive ductal or invasive lobular, then they start looking at the grade. So underneath the microscope, they'll look at the histologic and nuclear grade. The histologic is actually looking at the arrangement of cells in relationship to each other, and the nuclear is looking at how closely those cancer cells resemble normal cells. And then they'll grade them. Grade 1 is well differentiated, that cancers have relatively normal looking cells that don't appear to be growing too fast, all the way down to grade 3, which is poorly differentiated, which means that those cells lack any normal features of regular cells, and they tend to grow much more quickly and more aggressively. Doctors will also determine the ER status, which is the estrogen status. So they'll decide if it's ER positive, which means that it grows, that the cancer grows in the presence of estrogen, and progesterone status, which means that the cancer grows in the presence of progesterone. HER2/neu. HER2/neu is a gene that instructs cells to make a protein that is going to cause tumors to grow. 1 out of 5 cancers are HER2/neu positive. And I wouldn't say that we like cancers that are ER positive, PR positive, and HER2/neu, but you're going to see when we get to treatments that we have more ways to treat patients whenever their cancer grows and grows because of estrogen. Because For instance, then we can just withdraw the estrogen and hope that the cancer doesn't grow. Or if they're HER2 positive, we have medications out there, some that we can use to target that. So some of the most aggressive and dangerous cancers are called triple negative cancers, and those are ER negative, PR negative, and HER2 negative, because we really limit how we can treat those patients. Now, staging wise, I'm just going to kind of put these slides up here so you can see, but they use the T and M staging, which you've heard about, I'm sure. T means tumor, and if it's TX, it's usually that you can't assess the primary tumor, which is infrequent. Most of the time they can. T0, sometimes they can't see a primary tumor, but maybe there's metastasis that that indicates that there was at one point. TIS is carcinoma in situ, and then T1 through 4 vary based upon the size of the tumor. N means nodes, and NX means the lymph nodes have not or cannot be assessed. Most of the time, before women, they know they have breast cancer, but before they have had their surgery to assess their lymph nodes, they'll call them NX. But after surgery, they usually can determine whether they're N0 through N3, and it's all depending upon how many lymph nodes have been affected, and also if it's just axillary lymph nodes or if they've gone to the lymph nodes under near the clavicle, the supraclavicular lymph nodes. M is metastasis, and MX is that it has not or cannot be assessed. M0 is that there's no distant spread, and M1 means it's spread to a distant organ. Common sites for metastasis are the bones, the spinal cord, the brain, the lungs, the liver, and the bone marrow. I'll tell you that the brain and the lungs tend to be the ones I see the most, and I think it's just because of the proximity of the breast and for the lungs, especially the lymph nodes that are surrounded. There's a table in your book on page 1341 that you can look at this. Now, once they determine what T, N, and M they are, then they look at what stage. Now, I kind of watered this down a little bit because usually there's like stage, 1A and B and 2A and B, but I just kind of wanted you to get an idea that stage 0 is always going to be a tumor that is in situ, so it hasn't expanded out of the duct or the lobe that it's in. And it can't have any nodes positive, and it can't have any distant metastasis. And you're going to notice that if you have any distant metastasis, it automatically puts you to a stage 4. Any T, any N, but it's M1 is a stage 4. And then in between those two, it just varies on the size of the tumor. If it's a smaller tumor but more lymph nodes are involved, generally it puts you at a higher stage. It's important to know the stage because it directly relates to what your survival rates are. If you notice there, having a stage 0 cancer or a carcinoma in situ, you have a 93% chance of a 5-year survival rate. And most of those women, as long as they get treated and it doesn't get into a larger cancer, do very, very well. Stage 1 have 88%, stage 2 is in the 80s to 70s, stage 3 we're getting down into the 40s, and those little number 3B and 3C are starred because just wanted to pay attention that, even though you would think that it's kind of, stage 3 is 67% survival rate, you would think that a 3B would be a higher survival rate than 3C, but that's not quite how it works with stage 3. 3B actually has poorer survival rates than 3C. And then stage 4, if you see, that's kind of the scary number right there, that after 5 years, 15%, there's only 15% survival rate. So anybody with distant metastasis with breast cancer have a very poor survival rate. So, how do we treat it? There's several different ways. Surgery is one of the more common ways to treat, and radiation therapy is a way, chemotherapy, hormone therapy, targeted therapy, and bone-directed. And we're going to talk about each of these. One of the things I wanted to mention is that surgery and radiation therapy are kinds of local therapy. So those are targeted just to the tumor, and they don't affect the rest of the body. Chemotherapy, hormone therapy, targeted therapy, biotherapy, these are all things medications we take. So whether it's IV medications or PO medications, and so these are systemic therapies. They're going to affect the rest of the body, and they tend to have more widespread side effects. So some of the surgeries we're going to talk about, there's also a table in your book on page 1371. But first of all is breast conserving surgery. And you've got two different kinds of partial mastectomy or lumpectomy. Sometimes they kind of call it the same thing. But for most women with stage 1 or 2 breast cancer, they find that this breast conserving surgery plus radiation therapy is just as effective as a full mastectomy. Now, when we get to radiation therapy, we'll talk a bit more about it, but radiation therapy usually includes about 6 weeks of going to the center, the radiation center, every day, 5 days a week for 6 weeks. So some women would just choose to have the mastectomy because they don't want to have to deal with that. I don't know. I always feel like I wouldn't know how I would react until I was in that situation. Because there's some women who say, absolutely not, do not take off, I do not want a mastectomy, don't take off my breast, I'll do anything not to. And you have to let them be able to feel that and just kind of support their decision. But the good news is there's so much research out there that shows that breast conserving surgery and mastectomy tend to have equal results. Because a lot of women think, if I have breast cancer, I might as well just take them both off. I don't want to even have to worry about it again. So, possible side effects, you can definitely have pain, you can have swelling, tenderness to the site, you can have scar tissue that forms. But one of the main things is that if the doctors didn't get those good clear margins, or if the cancer comes back, they could definitely have to have further surgery. Next is mastectomies, where they remove the entire breast. They can do simple mastectomies where they remove the breast tissue, they remove the nipple, but they don't remove the underlying lymph nodes. Skin sparing surgery, this is whenever the doctors will remove the breast tissue. They'll sometimes can remove the nipple depending on where the tumor is, but they're trying to spare as much skin as possible so it will allow a better reconstruction if patients choose to do reconstruction following mastectomy. Then there's modified radical mastectomy. In modified radical, they remove the everything with the simple, the breast tissue, the nipple, but then they're also going to remove some of the axillary lymph nodes. And then there's radical mastectomy, where not only do they remove all of that, but then they remove the chest wall muscle. They've stopped doing that as frequently as they used to because they determined that these women don't have any really benefit, any greater survival rates, but they definitely have a harder time getting reconstruction done, and most of them, without a chest wall muscle, without skin, there's limited reconstruction that can be done. Now we're going to talk a little bit about how to take care of patients post mastectomies, because they can definitely have some side effects. Obviously, wound infection, that's a pretty large scar. Hematoma, so a collection of blood in the area, or seromas, which is buildup of clear fluid in the area. Also, if they have axillary node dissection, they can end up with lymphedema, which I'll have a picture of in just a little bit. So let's talk a little bit about axillary lymph node dissection. This is whenever they'll remove anywhere from 10 to 40 of the axillary lymph nodes, testing them to see if they're positive for cancer. Now, this can be a problem because about 30% of patients who have an axillary lymph node dissection end up with lymphedema, because the lymph fluid doesn't have anywhere to go because we removed all those lymph nodes and it just oozes out into the tissues. It's a big problem with people who've had lymph node dissections, and it's one of the reasons why we, after they've had a lymph node dissection, we don't want to check blood pressures, and we don't want to do any venipuncture on that site where they've had a lymph node dissection, because it can cause lymphedema, and also it can cause infection because they don't have those lymph nodes. So they've started doing more sentinel lymph node biopsy, which is when they inject a dye and see which lymph node is being drained to first from the area of cancer. And that is called the sentinel node. This is the first node that is being drained to from the cancer. They'll test to see if the sentinel node is positive, and if so, then they'll continue. They can continue down those lymph nodes. But if that sentinel node is not positive, then usually the lymph nodes below that should not be positive, and it helps prevent the side effects that a full axillary lymph node dissection have. They can definitely have some pain and swelling and bleeding, and definitely infection following these lymph node surgeries. If they do develop lymphedema, there's compression devices you can put on their arms, but it can be a real problem. Okay, reconstructive surgery. There's important to know that there's various different kinds. They can use flaps from the abdomen. They can use flaps from the back and from the hip, because if you think about it, you see the patient in, you see the picture of the lady in the picture A, and she's got no skin to form, to reconstruct her breast. And so sometimes they have to put in tissue expanders to start making that skin stretch and be able to hold a prosthesis, which either can be saline or gel filled, which you see in the picture B. And then in the picture C, they've done nipple and areolar reconstruction. So they've gotten very good at this, and I think that's why a lot of women have just decided just to go ahead and do mastectomies, because they know that they can have pretty good reconstruction now, depending on what kind of mastectomy there is. They have done. In the past, women who had mastectomies were pretty well limited to like a bra with, kind of like a stuffed bra essentially, which didn't look very natural, and that's one of the big emotional things they had to deal with. So thank goodness there's been some upgrades to that area. Post-operative teaching. These are things we just want to hit on whenever we're discharging a patient. Usually after they've had a mastectomy, they go home that very next day, and a lot of times they do have drains. And so we want to make sure that we let them know how to care for the surgical wound and dressing. Most of them have ACE wrap all around their chest, and then they just have the drains coming out. So they need to make sure to monitor that from excessive bleeding. Need to recognize signs and symptoms of infection. When they can take a bath or shower after surgery. Most of the time, not until the drains come out would we let them shower or bathe. We would want them to just kind of bathe around that area until the drains come out. When to call the doctor or nurse, any signs of fever or increased drainage. When to begin using the arm and how to do arm exercises. And there's a really good chart in your book, and there's a nursing care plan for a post-operative mastectomy patient on page 1321 and 1322, so I'd take a look at that. And also, one of the questions patients will have is when they can resume wearing a bra. And usually it's after the incision is well healed and the staples have come out, so around 2 weeks. You want to make sure, just for health sake, mental health sake, that they don't just lie around in their pajamas all day. because you never quite feel human if you're just lying around in pajamas all day. So you want to recommend that they wear like loose-fitting clothes while they're healing, just so they can start feeling kind of more normal. Doctors will tell patients when they can use a prosthesis and what type they can use after mastectomy. A lot of times they write a prescription, and there are companies that provide that. You want to teach them about their pain medications that they might need. Any restriction of activity, specifically in moving their arm. They probably are going to have some numbness or in different sensations to their breast or arm. There's actually a syndrome out there called post-mastectomy pain syndrome, and it happens in 20 to 30% of patients with mastectomies, and they complain of pain, tingling to the chest wall, numbness, and kind of like a prickling pain. They say it's not severe, but it's definitely there. So we need to kind of let our patients know that that could be a normal thing that we would hope decrease over time. We do want to address the emotional aspects about what to expect regarding their body image and when to follow up with their doctor. Okay, we're going to move to radiation therapy. I worked for a radiation therapist for about, radiation oncologist for about 5 years, and I didn't know a thing about radiation before I worked there. A lot of people are kind of scared, nervous about the fact that they're getting radiation. You know, you just hear that word and it kind of makes you scared. But it's really pretty painless for the patient. It's just like getting an x-ray. It's just that they have to come every day for however long. Like external beam radiation, which is one of the most common kinds and one of the oldest kinds, they come every day, 5 days a week for usually about 6 to 8 weeks. And they lay on the table just like they're getting an x-ray. They usually kind of tattoo a couple little dots on their skin so they to help guide them when they're doing their therapy. And you have radiation therapists who are actually doing the therapy, and you know, you're only there about 10-15 minutes each time, but it's just kind of annoying. You have to do it every day for so long. But I think once people realize what it is, they are less scared about it. Accelerated breast irradiation is a form of radiation where they give higher levels of radiation, but they give it in a shorter amount of time, like 3 weeks. So that's one option for some people. There's also 3D conformal radiotherapy, which consists of brachytherapy. Now, brachytherapy is whenever they actually insert radioactive seeds into a tumor. There's interstitial brachytherapy, where they just insert like a tube into the tumor cavity. So most of the time they've had a lumpectomy and they leave a catheter into that lumpectomy site. One of the most common kinds is intercavitary brachytherapy, which I have a picture here, and you see that there's this balloon that they blow up inside the lumpectomy cavity that's got a catheter coming out, and the patient comes, usually it's usually about 3 to 5 days. Sometimes they have to come twice a day though, and they have radioactive seeds placed inside the cavity, and it will irradiate the area that's got the breast cancer. And it's very short, and once it's done, they deflate the balloon and they just remove the catheter and balloon. It's pretty cool. Whenever I was working at the radiation oncologist office, we started doing this, and I got to see it on the first couple women. It definitely takes a coordination between the surgeon and the radiation oncologist, because the surgeon's the one who places the Mammocyte catheter following lumpectomy, and then the radiation therapist is going to be the one that treats them. So it definitely takes some coordination between your physicians. The last kind of radiotherapy I wanted to talk about was palliative radiotherapy. Now, palliative, you know, means that you're not being treated for a cure, you're being treated to help prevent symptoms and help usually it's decreased pain related to your cancer. And so with metastasis, a lot of times they'll they'll irradiate different areas, even though we know that it's not going to cure them. It takes a lot of education, especially the family, because they'll think that, well, they're still getting treatment, they're going to be okay. So we do need to make sure that the family's aware that this is not going to cure them. They're still eventually probably going to have the same poor outcome, but we just want to make them more comfortable. Side effects of radiation, specifically external beam has the most, because the radiation is coming from it's coming from outside in, and so it's got all this tissue that it's kind of irradiating. But women can have like a sunburn look to their breast, which can turn into like their skin looking like blistered, and it looks really painful. It looks just like a really, really bad sunburn, but it can cause a lot of impaired skin integrity. They can also have swelling and heaviness to their breast, and because of some of the changes that the radiation does, it can make that breast feel smaller and a little bit firmer. So different things you have to consider before doing radiation therapy, but it's good to know that there's some new treatments out there that are trying to eliminate or decrease some of these side effects. Okay, so we want to talk a little bit about chemotherapy now. Now, with chemotherapy, you have several different kinds. The word adjuvant mostly means, whether you use it in the form of chemotherapy or not, it mostly means that you're giving a treatment to kind of make the other treatment work better. So they do a lumpectomy and radiation, that's adjuvant. They do radiation and chemotherapy, that's adjuvant. So basically you're kind of like hitting it from two angles. So adjuvant chemotherapy, a lot of times it's after surgery. They think, we want to do something else to make this cancer go away, so we're going to give adjuvant chemotherapy. Neoadjuvant chemotherapy, and that word neoadjuvant means that we're going to do something before surgery. Usually it's to shrink the tumor. So it usually doesn't increase, it doesn't change our prognosis at all. But say a woman has a large tumor that a doctor's saying that she can't have a lumpectomy, she has to have a mastectomy, and she doesn't want a mastectomy, then they can try neoadjuvant therapy, whether it's radiation or chemotherapy, to try to shrink that tumor so she could have the lumpectomy. So that's usually the instance that they use neoadjuvant, is to shrink the tumor prior to whatever they're going to do. And sometimes tumors are in bad areas, like they're close to a bone or too close to the skin, and they need to shrink those before they treat it another way. And so that's whenever you use neoadjuvant therapy. You also use chemotherapy for advanced breast cancer. So if you have breast cancer that has metastasized, then a lot of times you're going to use chemotherapy to kill the breast cancer cells, but they just might not still be in the breast. Now, the next slide, I don't want you to get scared of and think that you're going to have to memorize all this. I just wanted you to show all the different combinations, all the variety of chemotherapy that women with breast cancer can get. And it's important to know that because, a lot of women have, whenever they kind of start ending up with a lot of friends who've had breast cancer, they have an idea and they think that they know what, well, they didn't do well with their chemotherapy and they lost all their hair and they were so sick, throwing up or whatever. It's just important to inform your patient that there's different regimens of chemotherapy that doctors give, and we have to let them know the side effects of that regimen that they're going to have. So kind of just so your patients don't have preconceived notions. Now they do commonly use the same, I mean, they, like whenever I worked for the medical oncologist where I gave, chemotherapy, the one that I would mostly see is this AC, the doxorubicin and cyclophosphamide, followed by sometimes the ACT, the paclitaxel, and sometimes I would see the cyclophosphamide, epirubicin, 5-fluorouracil. So it just depends on what the doctor has ordered, and how the doctor determines what kind of chemotherapy a patient's going to get is it targeted for breast cancer that's just still in the breast? Is it targeted for advanced breast cancer that's outside of the breast and now metastasized? What is the ER/PR HER2/neu status? What's the histological and nuclear grade? What kind of cancer? Is it invasive or is it non-invasive? And is it ductal or lobular? He's got to look at all of those things before they decide what kind of chemotherapy is going to work best. I did want to show you a picture of adriamycin because it's most commonly used, it's really commonly used for chemotherapy, and it's red, bright red. People call it like the Kool-Aid medicine, they call it the red devil, they'll call it all sorts of things. The side effects you need to know about adriamycin are that color red could tinge their urine, so they could have urine that's about that color. But also, what the red color to me reminds me that it is pretty toxic to the heart. So a lot of times before we give adriamycin, we want to get some baseline heart scans, like MUGA scans or echocardiograms, so we can evaluate, make sure that the patient is not having too much heart damage whenever we're treating them with this medication. Usually they have a lifetime dose limitation of how much adriamycin or medication similar to it they can have because of the heart toxicity. And there's other medications too, we'll talk about in a little bit, that have high levels of heart toxicity. So then hormone therapy. Now, I was telling you that it's with those triple negative cancers, it's really hard to treat them because we run out of options. They pretty much have radiation therapy and chemotherapy available, and obviously surgery. But when it comes to hormone therapy, they usually don't have this option because hormone therapy is directed at patients who have a ER or PR positive cancer. So the most common is tamoxifen and raloxifene. There's different ways that they can give this. They can give it 2 to 3 years, and then they can follow it up with 2 to 3 years of an aromatase inhibitor, or they can just give the tamoxifen or raloxifene for 5 years, or they could just give the aromatase inhibitor for 5 years. And there's even research out there that 10 years is better than 5. So it's just very dependent upon the doctors. We talked about how tamoxifen and raloxifene work. Tamoxifen actually prevents the estrogen from kind of like affecting the breast, and the aromatase inhibitors affect estrogen production. So that's how those vary. And we talked about Femara as being one of the more common ones, but also you'll see Arimidex, and that's pretty much the 2 common ones I see. Now, other things they can do are ovarian ablation, and they can do this several different ways. The whole purpose behind it is to remove the source of estrogen, the biggest source of estrogen, in premenopausal women. So they can remove the ovaries by an oophorectomy, it'd be a bilateral oophorectomy, or they can give medications, specifically the luteinizing hormone-releasing hormone. And these are Zoladex and Lupron are the most common ones that I've seen. And this will actually, it essentially makes the ovaries unable to produce estrogen, which would then kind of cut off that supply to the cancer. And I used to give Zoladex a lot, and it's like a little seed, and it's in this huge needle, like a 14 gauge needle, and maybe even a 12 gauge. It was huge, and we would have to numb the skin up either with like a topical lidocaine, or sometimes we would use ice packs and we just leave it on there. And whenever you're giving the injection, you're actually injecting the seed into their abdomen, into like their subcutaneous tissue in their abdomen, and that's what's keeping it and slowly releasing medication to prevent the ovaries from producing estrogen. They also have found use for these in prostate cancer. So, targeted therapy. Targeted therapy, it all depends on the type of cancer you have. So if you have, and I actually kind of miswrote that, I have to change this a little bit, but if you have a HER2/neu positive cancer, then the most common drug they're going to put you on is Herceptin. Now, they usually give you, you do lumpectomy, or you do your mastectomy, you do radiation, or you do chemotherapy, and then they'll put you on Herceptin for a year is usually the time frame they put you on Herceptin. And this has become pretty effective with HER2/neu protein positive cancers. Right whenever I moved to College Station, I took care of a lady at the hospital that she was about 6 months into her Herceptin regimen, and she would come every Friday for her Herceptin, and it was just about an hour long infusion, but coming to the hospital, it just took a long time. So we would always get her dinner tray or lunch tray, and I always felt bad for her because that was before we started having much variety at the hospital, and it was chicken fried steak every Friday, so I felt really bad for her because she had chicken fried steak every Friday for a year. But with my same patient, same lady, want to bring up the fact one of the big side effects with Herceptin is heart damage, and which will go into CHF. And ultimately, this patient developed CHF, and then her breast cancer returned, and then she passed away about 3 years later. But everything really, all the problems she had was pretty much related to her breast cancer, or the treatment of her breast cancer. So, Tykerb is another medication that they use for people who don't respond well to Herceptin but are HER2 positive. Afinitor, it is another targeted therapy that helps block a protein that causes the cancer cells to grow. And then Avastin, so the Afinitor and the Avastin are not HER2/neu drugs that target HER2/neu. That's the change I needed to make. But so bevacizumab or Avastin, that's a medication that will actually help decrease the blood supply to the cancer. Now, back in 2009, between 2009 and 2011, the FDA has decided to pull the indication of using bevacizumab for advanced breast cancer, because the research showed that it did not show much improvement on a patient's survival status. So they basically pulled the indication. The medication is still available. They use it extensively for colorectal cancer, but for breast cancer, they just pulled that indication, which mostly means that insurances tend to not pay for Avastin anymore if a doctor prescribes it for advanced breast cancer. However, it's still being used for patients who have been on it in the past. They kind of are grandfathered in. But it can cause significant amounts of bleeding, especially if you have a patient that has or needs surgery, because it's targeting the blood vessels that are going to a cancer. So, anyways, but really interesting research that's going on with targeted therapy these days. We talked a bit about bone-directed therapy and a little bit earlier in how there's some research out there about bisphosphonates and helping helping breast cancer. But I'll tell you the biggest reason that they use bisphosphonates, specifically pamidronate and Zometa, the zoledronic acid, is for people who have metastatic breast cancer to the bones, because it's going to help strengthen their bones and prevent fractures. It's not used to get rid of the cancer. It's not going to cure the cancer that's in their bones. It's just going to strengthen their bones. They usually take 4 milligrams every month or so when they have, and it's an intravenous drug, but whenever they have bone metastasis. There's another drug here, the denosuzumab, and this is a newer drug out there, and it is some people who don't respond well to the Iridia and the Zometa, they will put them on this, and it seems to help prevent fractures better than the bisphosphonates. So there's always new research, which brings me to the point that there's a lot of clinical trials out there for patients with breast cancer. Like I said, there's a lot of funding out there lately. I think women have a good way of speaking up for themselves and fundraising, and so there are a lot of clinical trials, and they're really looking at the targeted therapies a lot as ways to treat cancer, and also ways to more medications to prevent cancer. So you can take a look at that. Okay, we're almost done now. Just wanted to go over a few other little things here, specifically about complementary therapies and alternative therapies for breast cancer. Now, complementary therapies are therapies that go along with the other therapy we're giving them. So say they're getting surgery, say they're getting chemotherapy, radiation therapy, but the patient wants to do meditation, or they want to have acupuncture. Those are complementary to the treatment that they're getting. There's things like peppermint tea that a lot of people use, and they think that that helps relieve nausea. And some of these things have significant data to support. So it's definitely worth supporting your patient if they're looking into complementary therapies during treatment. There's also alternative therapies, which means that the patient is now not going to be getting the traditional therapy, which would include surgery or radiation or whatever, and they're going to do alternative type therapy. These are generally not supported by the FDA because there's no data to support the alternative therapy, and they find that it mostly just delays the treatment of the patient getting that they should be getting the chemotherapy or the surgery or the radiation therapy. Things that I've heard of these days are like the all-fruit diet that Steve Jobs did with his pancreatic cancer. And I'm sure that there's a lot of alternative medications, alternative therapies out there that are useful, but I'm kind of a research person, and I would want to see the research to prove that it's better than some of our modern medicines before I would jump into that. But we do need to support our patients and listen to them and give them all the risks and benefits and pros and cons of any of their treatments, so they can make informed decisions. Did want to talk a little bit about the cultural and ethnic disparities among women with breast cancer. We already talked a little bit about how white women have a higher incidence of breast cancer than non-white women, but African Americans actually have lower survival rates, even if they're diagnosed at earlier stages. And some of that, I think, is there's disparities among people who, in their treatments, I would say. So if they're unable to afford their treatment, even if they're diagnosed early, they're unable to afford their treatment, they might not be getting treated as well. Or if they have problems getting to and from their treatments, there's a lot of doctor's appointments that are involved in treating breast cancer. So I think that's some of it too. Breast cancer is the most common commonly diagnosed cancer among Hispanic women, and Hispanic women have the lowest rates of cancer screening of any ethnic group. And whenever I was working in Laredo, that was where my research was really focused on, was the healthcare disparities among Hispanic women in cancers. And like I told you earlier about that woman who came in who had the inflammatory breast cancer, and she was just in denial about the fact that she had cancer, or that anything was wrong. And some of it was that she was taking care of her older mom, and she didn't have time, and she needed to take care of her mom. She didn't need to take care of herself. And so some of that refusal to do screening, or the hesitance, is kind of a cultural thing. So, and lastly, Hispanic and African Americans are definitely more likely to be diagnosed at a later stage than white women. So these are different things we need to look at and see if we can help remedy. So after our patients have been treated, what are the things we need to remind our patients of? So they've been through their chemo, they've been through their surgery, they've been through their radiation. Most likely, they're going to have appointments with their physician every 3 to 6 months to evaluate if the cancer is recurring, or to evaluate for any side effects of the treatment. And then after 5 years, they usually move down to just going once every year, because most recurrences happen within the first 2 years or so. If they've had breast conserving surgery, they're going to need to get a mammogram 6 months after surgery and radiation, and then every year following. And if they've had a mastectomy on one side, they still need to get yearly mammograms on the remaining breast. A lot of tests like the tumor markers and the liver function CTs, those aren't a standard part of follow-up. But if the mammograms that they're doing every 6 months to a year do show recurrence, they will the doctors will probably start doing some of these other tests to see the extent of it. But they've just kind of determined that they don't need to continuously do these tests every year to 6 months unless there's a recurrence. Just a few other things to consider. It's kind of a scary thing for a woman if they do find a lump, and we need to make sure that we listen to them. We're calm, we give them facts, we let them talk, we assess their anxiety, because it's a really scary time, and a lot of people will kind of go into denial about the fact, and they don't want to get it checked because they think it might be something. So there's a lot of emotional things involved with that, so you just need to consider that whenever you're talking with women. There's lots of emotional aspects, like we've talked about. There's denial, there's grief that we need to address. There's a body image problems after breast cancer treatment, because some women are fine with it. They say, take them off, I don't care. And then some women really have a hard time with it, so we need to remember to approach everyone individually. Which then goes into the sexuality after breast cancer. If they have poor body image, it can really change their sexuality and their relationships. For those women who are younger and develop breast cancer, we need to consider if they can get pregnant after breast cancer, and it depends on what kind of treatment they have. If they have if they have some of the estrogen suppressing therapies, it's going to be very difficult for them to get pregnant following breast cancer. So we just need to take that in consideration whenever we're treating patients, if that's something that they still want to consider in the long term. Also, whenever you're pregnant, you have a lot of hormones being secreted, and that can actually cause breast cancers to reoccur, so that's something we need to inform them of. But most of the time, doctors recommend that they not get pregnant at least 2 years following therapy, because that's the most common time for breast cancers to reoccur. And then we need to consider the lifestyle changes that need to happen after a breast cancer treatment. Patients can become fatigued much easier. If they're getting chemotherapy, a lot of times they'll say that they get like a chemo brain, and which is like some confusion, and well, the patients say, I feel like I can't remember anything, and so that's what they kind of term chemo brain. And some people just don't feel well after the treatment, and so it's kind of slowing down their lifestyle. In addition to the doctor's appointments that are interfering with their life, wanting them to eat healthy, wanting them to exercise. So there's a lot of things to consider there. Here's all my resources, and I do have a case study that I think is just interesting that you can kind of look at and think about for yourself. But there's a 55-year-old woman who presents for an annual exam. She's 5'5", she's 189 pounds, she's 3 years post-menopausal. She had an older sister with breast cancer 6 years ago, so she's high risk, right? And she does not perform self-breast exams, and she doesn't like to look at her breast at all. And this is not an uncommon occurrence. During a physical exam, there was a mass palpated in the upper outer quadrant of the left breast, which we know is one of the common 50% of our invasive breast cancer are found there. And you can palpate the axillary nodes, and we know that palpating nodes is generally means that they're swollen, they're enlarged, and that's usually a significant for something. So the doctor orders a mammogram and a biopsy, and the biopsy confirms intraductal carcinoma. So I just want you to think about what risk factors she has, and can any of them be modified, and what psychosocial aspects can you explore, and what treatment options are available, and what follow-up should she be instructed to maintain. So just a few things to think about whenever you have a patient with breast cancer.